Good morning. Welcome, everyone. I'm Laura Colbert. I'm the Executive Director at Georgians for a Healthy Future. We are so pleased to see so many of you tuned in with us this morning. I am really looking forward to the day when we can safely and predictably gather in person again, but virtual gatherings like this will suffice in the meantime. We really appreciate you all choosing to spend your mornings with us when we know time is valuable and there's lots of ways to spend it these days. Many of you work in healthcare, in public health, and health advocacy alongside our Georgians for a Healthy Future team. And many of us see the everyday gaps in our health systems. These gaps really make it so that Georgians can't afford needed health care. If they receive health care, they're left with medical debt, or they have to make really tough choices about their health versus other necessities. Today, we're going to talk about those gaps and about how our state leaders can act to help fix those. Our conversation will focus on the results of a 981-person survey here in Georgia. And as you see the results, it's really easy to kind of get lost in the numbers and, the percents and, what is kind of the most responded answer, and to forget that each of those survey responses represents an individual Georgian. And I would challenge all of us this morning to keep the individual Georgia respondents in the front of our minds during these discussions. Just like us, these are folks who are making health decisions for themselves and the people in their families, and in many cases making tough decisions about health. When I look at the survey results, what comes to mind for me is a kind of that small feeling of dread that I get when I see an envelope from my health insurance company in the mailbox when I'm at the end of the driveway. As a household that's been without health insurance in the past, I'd say for about a month or so after any health visit, I have this little concern in the back of my brain about whether or not we're going to get hit with a bill that we didn't expect, or have to go back and forth with the insurance company about what they're going to cover and what they're not from that visit. These are the challenges that Georgians are seeing every day, some bigger, some smaller, and these challenges are not inevitable. We know that, and hopefully that's what our conversation will focus on this morning. We know that past reforms, past systemic efforts to bring solutions to the health system have made things better, even if they haven't solved every problem. But certainly Georgians going forward are always going to have some level of acute or chronic health conditions to manage, but we can reshape the systems in which they do that so that the system is easily accessible, so that it's predictably affordable, so that it's transparent, and so that it's accountable when it fails people. I hope that today's conversation, we can identify some really bold action steps that will move our public health and health systems in that direction, and certainly that will take all of us to succeed in that effort. I'm really looking forward to the program and hearing what our presenters think about all of this. Before we get there, a few technology tips for you this morning. First, you will have the best view of our panelists and the program this morning if you pin the coming up short panelists in your window. And the way you can do that is if you find the rectangle that says coming up short panelists, move your mouse to it and you click the three dots, and you'll get a menu that says the word pin, and just click that word pin. So that'll give you the best view of the program this morning. Please make sure you're muted and that you remain muted for the duration of the event. And then finally, there will be an opportunity for questions and answers after the program, or excuse me, after the presentations and after the panel. You can submit your questions either through the chat box or through the Q&A box. We would love for you to include a sentence about who you are so we know who's asking the question. And if the question is for a specific panelist, please say that as well. So please be generous with your questions. I know our panelists are ready and waiting. And with that, I will turn it over to our first presenter this morning, Amanda Hunt. Amanda is the director of Alterum's Healthcare Value Hub. In this role, she guides the hub's activities related to the monitoring of evidence, oversees the production of materials, and provides on-demand technical assistance to state-based consumer advocates like GHF. Prior to joining Alterum, Amanda was a health policy fellow at Missouri Foundation for Health, and she holds a master's degree in health administration from St. Louis University. Amanda, thank you so much for your work on the survey and for being here this morning.
Great, thanks so much, Laura. I'm going to invite my colleague Elise to go ahead and share my slides. But that was a really great introduction and a perfect way to kick off talking about the survey. So as Laura noted, my name is Amanda Hunt. I direct the Healthcare Value Hub at Alterum. If you're not familiar with us, we are a technical assistance and research center that supports consumer advocacy organizations who are working at the state level to advance policies that make the health system more equitable, more affordable, and more patient-centered. I'm here today to share just a few of the results from a recent survey that we did that really highlights Georgia residents' unbiased views on healthcare affordability issues and their support for solutions. Before I get started here, I'll just say that I can't see the slides. Are others having the same issue?
Can you see it now?
Yes, there they are. Okay, great. Let's go to the next slide, please. So I'm going to talk to you today mostly about the findings from the Consumer Healthcare Experience State Survey, which we know is a mouthful, so we call it CHESS. But first, I want to say a few things about the survey instrument itself. The survey uses a demographically balanced web-based panel of roughly 1,000 Georgia adults ages 18 and older to gather information about Georgia residents' experiences and opinions about the healthcare system. We fielded the survey from the middle of April to early May in 2021, during which vaccination rates in Georgia were slightly increasing. COVID cases, hospitalizations, and deaths were decreasing. And Georgia's governor lifted many COVID rules for businesses, including eliminating requirements for social distancing and masked employees. The survey was conducted in both English and Spanish and includes questions about COVID-19, among other healthcare affordability related topics. So now let's talk about what we learned. Next slide. Overall, 68% of Georgia adults reported having one or more healthcare affordability burdens in the past 12 months. Next slide, please. Affordability burdens include going without coverage due to the high cost of insurance, delaying or forgoing care due to healthcare affordability concerns, and getting the care they needed but struggling to pay the resulting medical bills. Almost half of uninsured Georgia residents cited too expensive as the major reason for them not having coverage, far exceeding other reasons like I don't need it and I don't know how to get it. Nearly 60% of respondents reported delaying or skipping care due to cost. And this includes things like cutting pills in half, skipping doses of medicine, or not filling a prescription, skipping a recommended medical test or treatment, or avoiding going to the doctor altogether. Additionally, cost was by far the most frequently cited reasons for not getting needed medical care. And it exceeded other things like transportation, difficulty getting an appointment, or lack of childcare. And finally, 50% of respondents said they got the care they needed, but they struggled to pay the resulting expense. Many reported being contacted by a collection agency, not being able to pay for their basic necessities like food, heat, or housing, and using up all or most of their savings, among other issues. Next slide, please. It's important to recognize that healthcare affordability problems are not just experienced by low-income earners. This is a problem that goes far up the income stream, with over half of people living in households earning over $100,000 per year, reporting struggling to afford their coverage or care in the prior 12 months. Still, Georgia residents earning less than $50,000 per year face the greatest burden, with 77% of those individuals reporting healthcare affordability problems. Next slide, please. While healthcare affordability burdens are high in all areas of the state, there are a few interesting differences when we look across regions. So all in all, residents of Georgia's East and Southwest regions report the highest healthcare affordability burdens in the state, with 71% reporting one or more healthcare affordability problems. The Northern region was close behind, with 69% of residents struggling to afford some aspect of coverage or care. Looking at the specific types of healthcare affordability burdens, we see that residents of the East and North regions were most likely to report delaying or foregoing care due to cost. Next. And the East and Southwest regions have the highest percent of residents struggling to pay their medical bills after receiving a needed service. Next. And while the metro Atlanta area residents don't fare the worst in any of these categories, healthcare affordability is still a serious problem. 64% of people in that region report having some healthcare affordability burden. Next slide, please. Given these findings, it's not surprising that the vast majority of Georgia residents, nearly 80%, report being worried about affording coverage and care in the future. Next. 3 in 5 residents are worried or very worried that their health insurance will become unaffordable. Next. 3 in 5 residents are worried or very worried about medical costs in the event of a serious illness or accident. Next. And 3 in 5 residents are worried or very worried about the cost of nursing home or home care services and medical costs when elderly. And what's interesting is that even though affording the cost of nursing home or home care services and medical costs when elderly are applicable solely to an older population, they were most frequently reported by respondents ages 35 to 44, followed by respondents ages 45 to 54. And this finding indicates that people might be worried about affording the cost of care for their aging parents in addition to themselves. Next slide. Additionally, we see that high percentages of Georgia adults of all income levels share healthcare affordability concerns. Although worry is highest among people with the household incomes of less than $50,000 per year, with close to 90% of people in this group worrying about some aspect of healthcare and affording healthcare in the future, still 70% of people within the highest income brackets report having similar concerns. Next slide. Okay, now I'm going to spend just a couple of minutes talking about some of our findings related to prescription drugs specifically, but I do encourage you to take a look at our standalone report on the topic if you'd like some additional detail. Next slide. Prescription drugs are one of the most, if not the most, commonly provided medical service in the United States, with over 50% of Americans reporting taking one or more prescription drugs. What's more is that over half of Georgia adults report being either somewhat worried or very worried about affording the cost of their prescription drugs. Next slide, please. As you might expect, worry varies by household income. 64% of people earning less than $50,000 per year report being concerned, but still over 40% of people with fairly high household incomes worry about the cost of their prescription drugs. Next slide. And ultimately, cost concerns have led 1 in 3 Georgians to either not fill a prescription, to cut their pills in half, or to skip doses of medicine. And slight regional differences exist here as well. Most notably, residents of Georgia's East region more frequently report rationing their medication due to cost compared to people living in any other part of the state. Next slide, please. In light of these healthcare affordability burdens and concerns, it's not surprising that Georgia residents are generally dissatisfied with the health system. When asked, just 39% agreed or strongly agreed that we have a great healthcare system in the US, while 62% agreed or strongly agreed that the system needs to change. Georgia residents see government as a key stakeholder that needs to act to address health system problems, and 56% said that healthcare should be a top priority for elected officials. When asked about the top 3 healthcare priorities that policymakers should work on, the top vote getter was addressing high healthcare costs, including prescription drugs. 41% of respondents selected this option. Next slide. The good news is that there's widespread support for policy change across party lines. Next slide. Overall, 87% of respondents think that the government should make it easier to switch insurers if your health plan drops your doctor. 86% said that the government should show what a fair price would be for specific procedures. 85% support requiring hospitals and doctors to provide upfront cost estimates to consumers. 84% support requiring insurers to provide upfront cost estimates to consumers. And 81% think that the government should expand health insurance options so everyone can afford quality coverage. Next slide, please. And that concludes the information that I have for you today, but I encourage each of you to view the reports after today's discussion. And you can always reach out to me at this email address if you have any questions after the call. Thank you.
Great, Amanda, thank you so much for sharing the results of the Consumer Healthcare Experience State Survey, or as we'll call it going forward, the CHESS survey. It's really eye-opening to hear how many Georgians struggle with affordability challenges, how many are worried about affording care for themselves or their families in the future, but also that there's broad support across party lines for strong policies that can address some of the drivers of healthcare costs. My name is Whitney Griggs. I am the Health Policy Analyst for Georgians for a Healthy Future, and I'll be taking over the rest of the facilitation for today's event. So I'd like to spend a little bit of time talking about what are some of these drivers of healthcare costs that make healthcare so challenging to afford for Georgians. So before I jump into what are the drivers of healthcare costs in the state, it's helpful to talk a little bit about what are the context of these healthcare drivers, how do they all work together, and kind of provide a little bit of a way to think about them before we talk about the drivers of healthcare costs in the state. Probably the most important thing to know about the drivers of healthcare costs, not just here in Georgia, but in general, is that they're all interdependent. That means that one will drive up another and another and another down the road. So when one cost goes up, it's affecting all of the other costs. And it's important to note that because that means that when we talk about policy solutions, you can't just look at one of the drivers of affordability. You have to look at all of the drivers of healthcare costs together and see how they're impacting each other across the board. It's also important to note that the drivers of healthcare costs, especially in Georgia, are unequal and disproportionate. That means that Georgians of color and rural Georgians are unequally and disproportionately affected by high healthcare costs. And we'll talk a little bit more about what that means and what that looks like when we specifically talk about the drivers. But what you'll see is that it often tends to snowball. One healthcare affordability challenge piles on top of another, on top of another, on top of another, and it's very difficult to get out from underneath, especially if you're already vulnerable to pricing shifts. Georgia is not alone in the challenges that we face with healthcare costs. Georgia faces a lot of the other challenges as southern states, not to excuse that, but there's a number of reasons why southern states face the challenges they do in healthcare access and affordability. But the good news is that all of these drivers of healthcare costs can be addressed through sound consumer-focused policy, which means that policy that's really focused on protecting consumers from high healthcare costs and focused on addressing these drivers of costs. As Laura mentioned, in her opening, let's keep consumers at the front and center of our conversations today and really think about how healthcare affordability burdens can really be a challenge for folks. And before we jump into the drivers, I want to take a moment to remind folks who may have joined after the introduction that for the best viewing experience, please pin the video on your screen that says coming up short panelists. You can hover over the video, you'll get 3 little dots and just select pin so you have the best viewing possible. One of the major drivers of healthcare costs in the state is probably no surprise to anybody on today's forum. Many Georgians are uninsured. 1.4 million Georgians are uninsured. At 13.7%, Georgia has the highest uninsured rate in the country. It has the 3rd highest uninsured rate in the country behind Texas and Florida. There are 480,000 Georgians in the coverage gap. So that means that they don't make enough money to qualify for financial assistance under the Affordable Care Act, but they make too much money or do not otherwise qualify for Medicaid because Georgia has not yet expanded Medicaid. Many of the Georgians that are uninsured are the working poor and already struggling with cost challenges. And as I mentioned before, healthcare costs tend to snowball on top of them. And as you can see in this map is rates of uninsured in the state by county. The more rural parts of the state have higher rates of uninsured, with some parts of the state having up to 37% rate of uninsured in the county. Georgia also has poor health outcomes. Again, I know that's not a surprise to anybody on today's call, and many Georgians live with multiple chronic conditions. So what that means in terms of healthcare costs is Georgians are needing more healthcare visits, and these visits are more expensive. We just talked about uninsured Georgians. If you don't have access to health insurance, you're not getting the preventive care that you need. And so when you do finally have to get care, perhaps an emergent or dire situation, it's going to be much more expensive. Georgia has, to put it lightly, an abysmal maternal mortality rate. Pregnant Georgians are 2 times more likely to die during pregnancy and postpartum during the national, compared to the national average. And a big driver of that is because women are not able to get the preventive care they need prior to getting pregnant. And so they're getting pregnant already managing multiple chronic conditions. And Georgia ranks last for access to healthcare according to the Mental Health Association of America. And Georgians report high rates of mental distress. So this means when Georgians are accessing mental health care, they're doing it in the most expensive ways possible. Perhaps they're going into the emergency room in an emergent situation, in a crisis situation, or perhaps they're accessing it through the justice system. Hospital mergers and acquisitions can be another driver of costs in the state. You've probably heard recently that there's been a number of acquisitions around the state. Piedmont Healthcare just purchased a number of hospitals outside of Atlanta. There's been out-of-state purchases as well. For example, an out-of-state company purchased Floyd Medical Center up in Rome. There's many good things that can come from hospital mergers, but they do have the ability to drive up insurance prices for insurers, which can then pass the cost on to consumers. And speaking of health insurance, high premiums and out-of-pocket costs can also drive up healthcare costs. Even small increases in somebody's monthly premium can be a challenge for them. If it's a family that's living paycheck to paycheck or on a very tight budget, even a $20 or $30 per month increase in their premium could mean the difference between them having coverage and not having coverage. Additionally, we've seen a trend towards high deductibles to help keep premium costs low. And while that's a good way for some folks to have insurance more affordably, it can also negate having insurance at all. If you have a $10,000 or $5,000 deductible, that means that you're likely probably not getting the healthcare you need if you can't meet that deductible because you're paying everything out of cost. And if you have an emergency or a dire situation that leads to you meeting your deductible all at once, you're likely going to have high medical bills or face medical debt as well if you can't pay that deductible. I will note that we do see some improvement among premiums in the state as more insurers join the marketplace, which is a reversal of a trend that we've been seeing with monthly premiums going up. Another component of health insurance that can drive up healthcare costs is inadequate or inconsistent coverage. One example of this is narrow networks. Health insurers will use a narrower provider network, so essentially a smaller provider network, to help cut down on costs. But this means that there's less options for consumers and it can force them to pay more. For example, if you're living somewhere where there's only one or two providers that are in network and none of the specialists you need to see are in network, you're either going to have to go out of network to get the care that you need, which means paying that out of network bill, or you're going to have to travel somewhere else, which could mean delaying care or paying more to just even access that care. Another example is mental health and substance use services may not be covered the same as physical health services, even though they're required to be under federal law. So individuals seeking help for mental health or substance use disorders can be forced to pay more if there is a limit on the number of visits they're allowed, the type of medication they can have, or even the number of providers that are in network close to them. They'll be more likely to have to go out of network or to have to pay for their own visits out of pocket compared to a physical health service such as cardiology. And then the final driver is prescription drug prices, which Amanda mentioned. Georgia ranks among the highest in the country for out-of-pocket drug costs. So that means that even insured Georgians are having to pay a lot of money for their prescription drugs. Nationally, this has been in the news a lot. I know it's no surprise to anyone, but prescription drug spending is on the rise. And just like all of the other drivers that we've talked about, those with chronic conditions really bear the brunt of high prescription drugs. If you think about an individual that's managing multiple chronic diseases such as hypertension and diabetes, they need high blood pressure medicine and insulin just to live. So they may put off other medical services, medical visits that they need just as much to get this medication that they need to survive day to day. So that's just a brief overview of the healthcare drivers in the state. We'll jump into these in much more detail with our panelists in a moment, but do want to give the opportunity for someone to ask one burning question of either myself or Amanda about the CHESS results or the drivers of healthcare costs. And as a reminder, if you're submitting a question, please either submit it into the chat box or to the Q&A box, introduce yourself in the question, and tell us who the question is directed for. All right, well, if there's no questions in the question box, Amanda, I have a question for you. Alterum has done this survey with a number of other states. How would you say that Georgia compares to some of the other states that you've done post or concurrent with COVID?
Yeah, thanks for this question. And it is one that we've gotten a lot. At this point, we've actually conducted the CHESS survey in about 20 states, and we have 2 more states forthcoming shortly. Because of differences in the times that these surveys were rolled out and what was going on in the world at that time, especially during COVID, and some slight changes that we've made in the tools over the years, we try not to compare results between states. One thing I will say, though, is that we conducted a survey in Massachusetts around the same time that we conducted a survey in Georgia. And it is very clear that Georgia's percentages of healthcare affordability burdens and worries are significantly higher.
Thanks so much for that question. Interesting to hear how Georgia compares to other states, but also that it can be a bit difficult to share. So thank you so much for your presentation, Amanda. We'll bring you back at the end for some more Q&A. And hopefully folks will jump in. So now I'd like to take the opportunity to move to the panel portion of the event. We're so excited to have an expert panel with us this morning to talk about the drivers of healthcare costs, the impacts of high costs on Georgians, and potential solutions to protect Georgia consumers from high medical costs. Joining us this morning, we have Erin Pusey Brown. Erin is the Catherine C. Henson Professor and Associate Professor of Law at Georgia State University School of Law. She's also the director of the Center for Law, Health, and Society at the law school. Erin's areas of expertise include health law and policy, healthcare finance, and consumer financial protections, among many, many others. Prior to joining Georgia State, Erin taught at Arizona State University's Sandra Day O'Connor College of Law. We also have Charles Owens. Charles is the director of the Center for Public Health Practice and Research and a clinical associate professor at Georgia Southern University School of Public Health. He's held a variety of healthcare leadership positions and worked with healthcare organizations across the entire continuum of care. He's provided oversight to various programs focusing on improving healthcare delivery system and health of Georgians in underserved communities. Prior to joining Georgia Southern, Charles served as the executive director of the Georgia Department of Community Health's State Office of Rural Health and Primary Care. And finally, we have Allison Sesso. Allison is the executive director of RIP Medical Debt, a national nonprofit that uses donations to eradicate medical debt and provide financial relief for millions of individuals and families. Prior to joining RIP Medical Debt, Allison served as the executive director of the Human Services Council of New York, an association of 170 nonprofits delivering 90% of the human services in New York City. Allison has been recognized as one of the most 25 influential leaders in Manhattan and was named by Crain's New York as a 2020 notable in healthcare. So again, thank you all so much for joining us this morning. I'm just going to jump right into the questions. And I know it's not surprising to any of you to hear that Georgians are struggling with high healthcare costs and worried about affording care in the future. Allison, I'd like to start with you. Could you just tell us a little bit if the survey results line up with what you're seeing among Metro Atlanta consumers with unpaid medical debt? And was there anything about these results that was surprising to you?
Hi, good morning, everybody. You can hear me okay? Okay, great. So first of all, thank you so much for inviting me and doing this survey. The results, unfortunately, are not surprising. We hear back from Georgians about the medical debt that we relieve for them, and the sense that we get. One of the things that really stuck out for me and that came across in the survey is the mental anguish that I think is often overlooked of not only the medical debt that you already have, but the medical debt that you might get if you go ahead and get care. So the fact that 58% of people delayed or skipped care is not surprising to me at all. And the fact that so many people are struggling to pay these bills. I mean, the fact of the matter is the cost of care is just landing in the laps of these individuals, and it's extremely unreasonable and increasingly so. The consumer, the patient, has very little control over the situation, and that is clearly coming out in these results and in some of the feedback that you see if you look more deeply at some of it. You're just vulnerable to medical debt regardless of whether or not you are insured. Although having insurance does provide you some level of protection. And I will say that unfortunately, as you've said, the situation is worse in a lot of southern states, including Georgia. The ACA in general is not perfect, but does help, and taking up the expansion does matter. And there are indications of that. Unfortunately, the situation for Georgians is worse in other parts of the country, as it is in other southern states for a variety of reasons. But what I really take away from all of this and what I see in my experience in terms of what we've seen from the responses from individuals who we've helped is the mental anguish and the lack of control over the situation. This is really a systems problem, not a personal failing. And I think we need to really make sure everybody understands that dynamic.
Thanks for that answer, Allison. It's really interesting to hear your perspective, being so familiar with not just medical debt in Georgia, but medical debt around the country. I'm going to move to Charles now. Charles, are these results consistent with what you see folks struggle with in rural Georgia? And same question as Allison, anything surprise you about these results?
It is. Thank you. The results are very similar in rural areas, if not even worse. In urban markets, you'll see a heavy concentration due to the large population. When we look at the same thing in the rural communities, the numbers are percentage-wise just as severe, but it's just a lower density population. So tends to make us think that it is less likely or doesn't occur at such a rate. But comparatively, yes, they are very similar. The thing that really surprised me was when you looked out and we saw that Southeast ranked more severe than Southwest. Southwest always gets the recognition of being the leading when it comes to poor health and poor outcomes and typically affordability. However, I noticed kind of, and it depends on how you carve up the areas, and there's no right or wrong way, but it did seem when I looked at it and was trying to figure out, well, what made that shift? It appears that perhaps the I-75 corridor fell into the Southwest area. And so it brought in some better health, if you will, to probably lower some rates. And then also, I think the Eastern went up a little bit higher. And so when you look at that as well, because, Georgia's stroke belt, poor birth outcomes belt, that always runs from Southwest to just south of Atlanta up to the east side. And so, catching that upper east quadrant really would have escalated those rates too. So, but yes, very consistent from rural versus what you're seeing in the urban underserved market as well.
Thanks for the answer, Charles. And you bring up a great point about the data and, how you carve up the state matters. And we consistently see when we talk about poor health outcomes or uninsured rates in the state, that it is this particular strip of the state that seems to always fare the poorest.
Right.
So Aaron, now we'll move to you. Based on the trends that you see in healthcare pricing and policy, do the Georgia results make sense to you? And same question is to everyone else. What surprised you about the results?
Hi, yeah, and thanks for having me. This is a great project and great presentation today. So in terms of health pricing and healthcare policy trends, one thing that did stick out is, you did a great job of presenting the drivers. And one thing that people, think about, of course, it seems obvious that one of the big drivers is the level of insurance coverage in a state, and that might change regionally. It changes rural to urban. But I think that the thing that you highlighted that's really important from a pricing and structural standpoint, it's not just coverage, Medicaid expansion, that's huge, but also the degree to which the the healthcare provider marketplace is consolidating. And that is really what's driving the prices up across the country. And it's true in metro areas, urban areas, as well as, of course, rural areas can only support maybe one big provider. We're seeing that. We see that in Georgia as well. But that healthcare consolidation, it may seem sort of distant and it's hard for consumers to understand, how is the merger of this hospital or buying up my physician practice? How does that translate into higher prices for me? Well, it means that they really can have the market power to demand higher and higher prices from our health insurance companies. And if you have insurance, you're seeing your prices go up as well. So I think that that's one of the big trends that we're seeing across the country, and we're seeing it here in Georgia as well. And in terms of things that are policy trends, I think there's been a lot of coverage and in Georgia, because we had our own state surprise medical billing law, thanks to Georgians for a Healthy Future, that passed a couple of years ago. And then, of course, now we have the No Surprises Act at the federal level. And I think a lot of people are wondering, is that going to solve the healthcare affordability crisis? Because we have now protection coming on January 1st, 2022 for the whole country. We have no out-of-network surprise medical bills will virtually go away for most care settings across the country. And yes, that does provide consumers an added level of important protection, that you will not go to the emergency room. It's an emergency. You can't choose whether or not the physician is in network or out of network, and you won't get a balance bill or a surprise bill from that anymore. However, that doesn't eradicate the problem of affordability. It doesn't eradicate the problem of medical debt. And I think that Allison is probably seeing that as well, because, New York has had surprise medical billing laws in place for quite some time now. So I think that that's something for people to keep in mind, is that this is a multifaceted, very complex problem, and solving one part of it, eliminating out-of-network surprise medical bills will help, but it will certainly not eliminate the problem, because we have so much in the way of just even in-network care, high deductibles and all the things that people who are uninsured, prices going up, I think that the burden is still there. And unfortunately, we still need to tackle this problem. As far as things to be surprised, unfortunately, I wasn't really surprised by the findings. I think that some of the regional differences were sort of interesting, but I think the main takeaway is it's very consistent with what we've seen with national surveys in terms of the burdens, particularly in southern states that have not expanded Medicaid, in terms of medical debt, affordability, and as Allison pointed out, the mental anguish, but also the degree to which people are sacrificing their necessary items like food, prescription drugs, getting the necessary chronic care that they need, paying their rent. They're making really tough decisions. And I think people's health, not only their mental health and their physical health, are suffering as a result.
Thanks so much for that answer, Erin. And I really appreciate that, you and Allison pointed out just the mental anguish that this affordability crisis can cause someone having to make really difficult choices about what you're going to afford that month, or even knowing that you have a medical debt that's really severely impacting your life. And Erin, I appreciated, mentioning the mergers and acquisitions as well. I think it's something that we're seeing pick up post-COVID too, as so many hospitals struggle to make it through COVID as well. So we'll move on to the next question, which is really focused on affordability burdens. So the results of the survey, as Amanda mentioned, found that almost 70% of Georgians experienced a healthcare affordability burden, such as being uninsured, delaying care, or struggling to pay medical bills. So this is a free-for-all answer, whoever wants to go first. What are some of the systems and structures in Georgia that make healthcare unaffordable? And how do these systems and structures disproportionately impact Georgians of color and rural Georgians?
This is Charles. One thing I think that we struggle with, and it helps to drive up our cost, we have struggled with a workforce shortage forever when it comes to healthcare. And, we see availability of healthcare providers go up and down, but with COVID in particular, and we know it's an anomaly, and we hope we don't experience another COVID experience in our lifetime, or anyone else's lifetime for that matter. But it really magnified what happens when you have so much demand with so little workforce. And so just as we saw with, nursing salaries, we didn't have enough nurses, so we were bringing in agency nurses and paying such high cost. Well, the same is true outside of COVID, especially in rural markets where you have a very limited labor force with the license and skill sets that you need to staff a medical facility, whether if it's a hospital or a clinic. And so you do wind up paying more. And, until we are able to overcome our workforce shortages, it's going to be really hard to bring down a lot of our cost. Most of our rural hospitals and many of our rural primary care providers are nonprofit organizations. And so they work hard to make sure that they maintain a good quality healthcare service at a quote unquote affordable price. And I put that in quotes in the air there for a reason. What is affordable to someone who's experienced in healthcare, and you grasp and you see the cost, and that the x-ray machine costs 1.5 million, or the cost of the chemotherapy drugs, you can kind of grasp and you see it. But to people outside of the healthcare world can't fathom, and it seems so unfairly exorbitant. And so until we figure out a way to kind of find a balance, one with workforce supply, but also being able to manage the technology part, because the technology, the more we advance our technology, the higher our operational costs have become. And so, we want to be able to view our medical records on our computers and on our smartphones and easily share, but it comes at a cost. And so I'm not saying that it's a negative, I'm just saying it comes at a cost. And so when we talk about things to contribute to how expensive our healthcare system is, we need to think about the context of our system. So
So
thank you.
I just wanted to, I agree with what you're saying, Charles, and I really agree with what Erin said earlier about the consolidation of hospitals. And we do need to look at the price of things in the healthcare system. And that's definitely something to do. And I think transparency can help with that, but it's not the final answer, right? So like, first you have to see the problem and then you can solve it. So I think that transparency is a step, but we have to know it's not the finish line. The other thing, though, I think is the other side of the equation, which is the affordability, like the individuals. Why can't people afford? I mean, what I see is people not being able to afford, and some of this came out in the survey, $400. I mean, that is part of the problem too. We're not talking about medical debt that's just people not being able to pay some bill that they unexpectedly, was like they got hit by a car or a bus, which is the classic thing that people that don't think a lot about this and aren't in the weeds think, oh, you get medical debt when you get hit by a bus all of a sudden and you have this, big bill. And the reality is a lot of medical debt is routine care. It is, you have diabetes and you can't afford to have diabetes in the United States. It's the GoFundMe pages, the ones that are successful are the heartbreaking stories of, a little girl who has cancer, as opposed to the, 50-year-old man who can't afford his, routine medication that he needs. And obviously the situation in terms of drug prices, according to your survey, is worse in Georgia. And so that's something to look at. But I think we have to also think about this as a economic system being broken, not just the healthcare finance system being broken. The fact of the matter is people are making choices about what they can pay for. And frankly, a lot of people, I think appropriately, are deciding to pay their rent or buy food and they are not paying the hospital. And so that's where you get medical debt. And then you have to deal with that later. But the fact of the matter is, if you're hungry, you're going to feed yourself. If your landlord's going to come and try to kick you out, you're going to pay them before you're going to pay the hospital who, maybe it'll get on your credit report, but that's really not a tangible problem in the moment. And that's something we have to think about. And unfortunately, it's not just the poor person that's dealing with that. It's actually more and more of your average middle American, that's struggling to make choices and make ends meet at the end of the day. And I think that's a element we have to think about. You also asked about the racial implications, and those are definitely real and significant. There was actually recently a report by Brookings Institute that talked about a little bit about this that I would encourage people to look at. And it said that 27% of Black households hold medical debt compared to 16.8% of non-Black households. So, there are indications for Georgians as well, the differences in race. And there's no question that obviously our racial history sits in so many facets of the problems, the social problems that we deal with. And it's no different for medical debt.
I would agree with everything that was just said. And I would just add that the sort of systemic picture of the structure of, again, the economy and the inequities that are baked into the economy show up in this problem. And that is why we see communities of color being more burdened by unaffordable medical bills, by medical debt and collection actions. And the reason is that, just from our history, there, Black communities, Hispanic, Latinx communities, and other communities that have been sort of unable to amass wealth. They don't have access to the jobs that come with health insurance as much. And so the levels of wealth and the levels of insurance, those two things are very good predictors of whether you're able to weather that unexpected $500 or even expected $500 bill from in a healthcare encounter. And so what we do see is that that's showing up in the data. And the one, I know we're going to get to solutions later in this conversation, but if there's one thing that a state can do, and there's been empirical, research about this, it is expand Medicaid. Expanding Medicaid has like the single most significant impact on rural communities, on hospitals, and on communities of color in terms of making healthcare more affordable for that sort of that most low income spectrum of the population and the hospitals and physicians that serve them. And so it'll help with the workforce issues that Charles mentioned. It helps with the sort of structural issues that Allison mentioned, because you're not having to choose between paying your rent and paying for your healthcare if you have Medicaid coverage. And so that has been shown time and time again, is that the burdens borne by not only communities of color, but rural communities and poor communities in terms of medical debt and affordability are much smaller in those states that have expanded Medicaid. So that is something that we could do tomorrow. I know that there's other issues politically in Georgia, but that is something that we could do tomorrow and make significant headway against this problem.
Thank you all for those really thoughtful answers. We started to kind of move down this road, so I'd like to ask the next question about medical debt. Half of Georgians reported getting the care that they needed, but subsequently struggling to pay the resulting bills. And according to the Urban Institute, 19% of Georgians have a medical debt in collections, which is higher than the national average of 15%. Medical debt is, as we've talked about, especially burdensome to communities of color in Georgia, with 21% having a medical bill in collections. So I'll first kick this question off to Charles and Aaron. What creates these massive medical debt burdens in the state, and how are these compounded for low-income Georgians?
This is Charles. One thing, how is it compounded is someone has that event. That event happens, and all of a sudden you now go in for treatment, and then perhaps you need to have a surgery or have a procedure done, and you're sitting there with a $1,500, $2,500, $4,000 deductible. And so it just takes that one event. And, the data that has been presented here was so telling, because, so often when we talk about underservice and affordability, we think of it as a low income, a quote unquote low income challenge, however it's defined. But if you look at the data that's presented here, it really goes pretty high up the income scale, especially for most Georgians. And so when that event occurs, most people don't have that deductible in savings, in a health savings account, or even in their checking account. And so without that savings, even if you take two working professionals, say two teachers that are a family of two or three, they don't have that nest egg that's waiting to fill a healthcare. They have a house, they have a car, and they may not be, low income, what we perceive to be low income. However, at the end of the pay period, once they pay their bills, they don't have a lot of discretionary money. And, you can argue all day long if they have a too expensive mortgage or a too expensive car. But at the end of the day, they still don't have money set aside for healthcare, which is what the conversation is today. And so while personal choice might not have been the best, the situation has arisen and the person is struggling. And so that's what we want to help them not have that challenge. I think that is probably one of the biggest drivers, is that surprise and the sticker shock from the out-of-pocket costs, whether if it be deductibles and co-insurance. Most of us have a plan that pays about 70%. So you have a $10,000 surgery, you're ready for a $3,000 out-of-pocket just for the hospital. But then you add on anesthesia, then you add on, every other person who played a part in your healthcare, or provider, I should say.
And I think that complexity also makes it worse, right? And the idea that, we've all had that experience of going to the doctor or going to have a procedure done, and then afterwards just sort of like cringing and closing your eyes as the bills start rolling in. And then you get the explanation of benefits from your health plan that says, this is not a bill. So you're like, okay, well, does my insurance take care of this? Is this just the first bill? Is this like, at what point is it my responsibility? Are some of these bogus? You can't understand them. They're written in jargon, right? And so because you get not just one bill that's really well explained and says, okay, this is the amount you owe, you get, 50 bills. Each one of them said, might have a different number, and, it might change over time because insurance is taking care of part of it. And it's very, very difficult even for, someone who does this for a living to track it, and it starts to become overwhelming. And if the bottom line number is starting to be something that you can't face or you can't afford, a lot of people get overwhelmed and they just like shove it in a drawer, and then it becomes a medical debt. It goes to collections, and then interest gets piled on, and then it, maybe it shows up, a debt collector is then hounding you, and then you just get more and more afraid, and you don't have the money for a lawyer to go show up in court and fight the bill, even though you think it's bogus. Yeah, I mean, it is like the worst consumer experience. It's like worse than buying a used car. It's just so confusing, and it's so difficult that I think it's hard for anyone to manage, and it's particularly hard for someone who is under stress, who is under resource constraint, to really think through. It's hard for any of us to deal with that. So I think that compounds the medical debt problem, both for the low income, but as well as Charles said, like for anyone. I mean, this is a really hard system to navigate.
Yeah. And Erin brings up a really good point. I'll make this just real quickly. We almost need a consumer healthcare education class just so that when you go to expect the radiologist bill. Most people who are non-healthcare oriented have no clue, having worked in the healthcare environment. And many a times I've had people literally come into the office and just say, what are all these bills? And we would sit there and open them together, and you would explain, this is the pathologist. Well, who's the pathologist? What is that? Here's the radiologist bill. Because people don't know, you don't see those people. And so you don't know they're part of your delivery team and also going to bill you, not to mention anesthesia. I mean, the list goes on. And so we actually, the earlier we can start to introduce, when we talk about health to our students, to also have a conversation about healthcare finance as well. As someone who teaches healthcare finance, I think it's important to my students. But they're in public health and they want to know about it, but we've got to make sure everybody knows about it so that it's common. And I know that how hard that is when you're starting, pretty low in an educational priority. I'm not saying it's a low priority. I'm just saying there's reading, writing, arithmetic ranked top. So when do we have that conversation, and how do we get it to be a part of every family's knowledge bank?
You both made great points. Charles, to your point, I never learned how to pay taxes in school, and I never learned how to educate myself about healthcare spending. And that seems much more important than the calculus that I've never used outside of high school.
Yes.
So thank you for those thoughtful answers. And Erin, to your point about these medical bills and the explanation of benefits you get. I had a baby a year and a half ago, and that bill that you get that itemizes the Advil that you get and how much it costs, to your point, I live in this world and I was still stunned by a bill like that. And I, did that. I put it in the drawer. I was like, we'll see what insurance sends me. So Allison, you have a really unique perspective on medical debt, and I'd love to hear, based on your work, what have you observed? Have you observed Georgia consumers having more medical debt than other states? And have you seen these disparities in medical debt between white communities and communities of color?
Yeah, so first I just want to respond a little bit to the financing classes, which I agree with. I'm not disagreeing with that, but it reminds me of my own criticism of the work that we do. Like RIP, our work is to buy medical bills directly from hospitals and relieve people of those debts. We've relieved $5 billion of debt. It's great. Wow. And I am appalled that I have to do this work, right? I'm sort of like blaming the victim a little bit. Like, I do think that standing up these figure out your way to navigate the system better and let some nonprofit come in and fix the problem, doesn't fundamentally get to the issue. And I just want to name that, because I think it's important that we don't lose sight of the fact that we fundamentally need to think differently about this problem, and not just expect, because the expectation that people have to pay a medical bill and sacrifice things. Like you talked a little bit, Charles, before about the nest egg and how people don't have it. It's also killing existing nest eggs left and right? And so it's I get it that there's this personal responsibility element of it, but I do think it's unreasonable how much we're asking of people. And I do think that, yes, you might say, well, you shouldn't have to be able to take that trip to Disney with your kids if you had this medical bill. But like, is that reasonable? I mean, you only have so much time in life with your kids. Are we creating reasonable expectations for how we want to live our lives in the United States? I just want us to sort of question those things fundamentally. But to your question about, what we see. I mean, what I can tell you is that we are evolving our model at RIP. We've only been around since 2014, and I expect that in the future years we'll have a lot more data and be able to do more comparative analysis to answer that question, better. Although I hope that we make progress on the problem in the meantime, and so the problem will be better. But I can tell you this: we have not had any problems at RIP Medical that accessing debt in Georgia historically, and we have had problems accessing debt. It doesn't mean that debt doesn't exist in those other places. This is fundamentally how we have historically purchased debt at RIP Medical Debt. We have generally bought it from the secondary market, meaning that a hospital sold that debt. So hospitals in Georgia are selling their debt to debt collectors. So that's something to flag for people who are concerned about the consumer experience, because there is a built-in desire then to make a return on your investment if you have gone and purchased a bill from a debt collector. I mean, how RIP is able to do such great work is that we're able to buy the debt for pennies on the dollar because it is sold to debt buyers for pennies on the dollar, because they know that the chances of them recovering that money is very little because of you're getting, blood from a stone, as they say, right? It's like really hard. So we're able to take, $1 and buy $100 of what somebody would owe in medical debt, which, we should stop and think about that. That's a little bit of a crazy situation, but that's how RIP essentially works. So I would just say in terms of the what's going on in Georgia specifically, they are selling debt. Also, not all debt shows up at the collection agencies. Not all debt goes to credit reports. Some hospitals increasingly actually, and I think quite quietly to some degree, are not actually reporting medical debt to credit agencies because they are sort of understanding the impact of medical debt on individuals and that people really can't pay. Frankly, hospitals would much rather get paid from insurance companies than they would from the individual. And we are turning them into these entities that and they're having to add costs to their bottom line to actually try to recover funds from individuals. And I think we have to, consider that. So I know we're going to turn the conversation a little bit to, solutions. And I just say that there are solutions and things that hospitals can do and not do. And some of them are doing that, that would impact this. So I'll stop there.
Thanks for that answer, Allison. And when you kind of made this point, when I learned of RIP Medical Debt and your work, it's incredible work. You guys may have heard of RIP Medical Debt because John Oliver did a special on them as well. But only in America could we have a system like that. So it's really interesting to hear your perspective on that. Thank you so much, Allison. And as you alluded to, we are going to talk a little bit about solutions. And for the sake of time, I'm going to combine the solutions conversation. So respondents to the survey reported that they believe that high costs in healthcare were due to unfair pricing by powerful stakeholders. And then, as Amanda mentioned, the survey also found strong bipartisan support for government interventions to improve healthcare affordability. And there are a myriad of policy options to improve healthcare costs for consumers, some being more appetizing to policymakers than others. So I'd love to hear from all of you. One, what are some changes that can be made by providers and health systems, insurers, drug companies, realizing how broad of a question that is, to address these affordability burdens? And then what are some steps that state policymakers can take to improve healthcare affordability?
So I can jump in on some of the stuff that I think hospitals can do, because this is fundamentally where RIP has been working. So as I mentioned earlier, we used to buy debt primarily almost exclusively from the secondary market, meaning it had been already sold to a debt buyer. We are shifting and working directly with hospitals. And in fact, we one of our big deals was mentioned in the Wall Street Journal back in March. We did a big buy of almost $300 million in debt by working with a hospital and Valid Health. And we're actually very much focused on Atlanta and working with the Archie Collaborative to try to buy a bunch of debt in Georgia, so in Atlanta specifically, so pay attention to that. But I would say that one of the reasons why we're working with hospitals is because we want them to look at their charity care policies. Most hospitals are nonprofit hospitals. There are charity care requirements, and we want to make sure that there is caps on how much one person can owe, that the actual approach to accessing charity care is clear, that that there's some hospitals that do presumptive charity care, meaning you don't apply. They naturally look at how much, they take the data from TransUnion, which is the same way RIP evaluates people and their ability to get their debt relieved by us. You buy data from TransUnion or another provider and look at people's income. Don't garnish people's wages. Don't sue individuals. I'm not sure those things really pay off in the way that we want them to. And let's remember that fundamentally, medical debt itself is a social determinant of health. And so by doing those actions, hospitals are undermining their goals of population health. And so they have to decide, in that moment when they think about billing and collections practices and charity care policies, about which thing they're leading with. Are they leading with their mission or their margin? And I think that really, matters. And hospital leadership needs to really think about that. At the same time, I will say that this healthcare financing system does fall in the laps of hospitals in an unfair way. And so I don't necessarily think that there are these evil entities that are doing, bad things in the world. But so I think one of the answers, frankly, is in charity care policies and really looking at those. And as we do our work with hospitals, we are hoping to look more at charity care policies and give them data and information that help them reflect on those policies.
I think that's a really important point, Allison, and I'll take this sort of state aspect, state policymaker aspect of the question. And I put a couple links in the chat. I don't know if that's visible to the whole webinar or if that's something that the organizers can make available. But there are lots of things state policymakers can and are doing to address this problem. And I think that one of the things is to note that there are lots of models out there. That's why I put the two links in the field. One is a model act by the National Consumer Law Center. That one's sort of shoot the moon. What would you do if you could wave a magic wand? The first thing I would do if I could wave a magic wand, I just want to reiterate that, is to expand Medicaid. But the second thing I would do is, once the debt is created, is to create these consumer protections at the state level. I mean, there are a few federal consumer protections in the IRS rules for tax-exempt hospitals, but those are really under-enforced and they leave a lot of discretion for hospitals in the area of charity care and financial assistance and collection policy. So states are really moving into this space. And just this past year, Colorado, Maryland, Illinois, and New Mexico all passed laws that really sort of strengthen those consumer protections against medical debt collections and creation. So some of that is sort of requiring across the board financial assistance policy threshold. So everyone under 250% of Medicare, the federal poverty level, cannot be, sent to debt collection. That there is a much more affirmative responsibility to establish payment plans for patients who can't afford the whole sum of their medical bill in one setting. And then also, limits on the types of debt collection practices, no foreclosures on homes, limits on when you can send a bill to a collection agency, when you can sue a patient and garnish their wages. Those are the types of things that states are really moving into this space and being really proactive and putting in place much more firmer guidelines for hospitals and leveling that playing field so that all hospitals have to comply with the same sort of levels of financial assistance. They can always go above it. And there are also exceptions for community access hospitals and rural hospitals. But I think that there are lots of things states can do. And I think that that's what a lot of those examples are both in the NCLC report. And then the second link is a report I did about a year ago for the appeal that at the end, there are some appendices with all these different state laws. And so Georgia doesn't have a whole lot in this area, but there are lots of states, and not just blue states, not just coastal states, but states all over the spectrum that have done things to protect consumers, particularly the most vulnerable consumers, from medical debt collections and the burdens of medical debt. But I think we also have to think upstream and prevent that debt from being created in the first place. So whatever solution we do has to have both of those in mind.
This is Charles. I would just like to add to that. I think if as we look at opportunities to help communities address social determinants of health, making sure that people have housing and safe housing, as well as food. We've certainly seen where several of the for-profit side of healthcare has taken large strides in investing in social determinants of health. We've seen that with managed care organizations, as well as there was a recent article where CVS was investing a few $100 million in housing, which sends a clear message that as a pharmacy retailer, they find value in people having quality housing near their stores. It sounds like they're good patients, good consumers of their business. And it's also, I'm sure there's a somewhat of a spirit of giving back as well. Also, continuing to grow the workforce. When there's a lack of access to services, people delay care, and care is oftentimes higher. So how we can work to grow the workforce, especially that in primary care, is critically important. We've seen in Georgia where we've made great strides in not only producing physicians and nurses and other healthcare professionals, but I think the more that we can do in that arena will help us have more of a supply for our demand in the market to help bring down some cost. Also, we've invested heavily in the expansion of federally qualified health centers, which I think continues to be an important critical need across our state. And the great part about the FQHC investment is it creates a safety net provider in the communities that they serve, but they not only focus on primary care, but also mental and dental health as well. And when you have that broad spectrum under one umbrella that can meet all of a patient's needs across that spectrum, they'll be much more likely to be successful at having a great quality of life. And it goes without saying, we've of course invested in telehealth, and thanks to COVID, one of the positives of COVID is we've embraced telehealth finally, after 40 years of trying to get telehealth deep rooted in our state, and we have seen that with COVID. And so seeing that continue, because it makes it easy to access. People don't have to miss work. People can see it from home, from their job site, from wherever they are, their schools. And it's a great tool and a great resource. And it also fills that gap where we may have met the primary care requirement, but if we could link that patient then to a mental health provider or dental provider, integrating that with our schools, each one of those, I think, are key steps in us making great progress. And some of those, as I've said, we've done for a few years and we've seen the return on the investment. I think it is important to measure that return and tell that story so that people know that the money was invested well, there is a return, and what that impact is.
Thank you all for those answers. I think we could have a whole separate hour-and-a-half panel on solutions and stakeholders. So maybe we'll look at doing that down the road. But I do want to give folks on the call the opportunity to ask you all questions. So we'll bring back Amanda as well in case people have questions about the survey results or the survey process. A reminder about the questions: please introduce yourself when you submit your question and say who the question is for. You can type your question into the chat box and I will read them out to the panelists. And it looks like we already have a couple in here. So this is from Sherry Williams at the Global Partnership. She says, I run a small nonprofit telehealth company, and we are having a really hard time finding decent and affordable health insurance for our employees. What can we do? Our current policy ends in November, and we do not have any real options for our employees. How do small businesses provide coverage for their employees?
That is a really tough one. I think that is something that the Affordable Care Act marketplaces tried and didn't necessarily succeed in fixing, which is fixing the very variable, spotty, and sometimes expensive small business insurance market. So I think that that is one place to look, though. There is no shop marketplace, so to speak, but there are small business options for people who are in that space. And unfortunately, I think that sometimes is, particularly with the additional enhanced subsidies available under the American Rescue Plan, that still might be the best option for workers in a small business, rather than trying to go out and buy a policy for the entire, for the entire small group, but to send people to the marketplace to look for coverage. But I think if anyone, Charles or anyone else, has additional thoughts.
The marketplace was what I was thinking probably as well. And perhaps finding a patient navigator nearby. I'm not sure the status of all the patient navigators that were deployed originally. I know they are some that are covering the state in different regions.
And I think that is something that is, the last time you checked was a year ago, check again, because the American Rescue Plan that passed earlier this year really did, and the Biden administration pumped money back into the Navigator program, there are additional, like I said, enhanced subsidies to purchase healthcare, so it doesn't end at 400% of FPL anymore in terms of the access to subsidies. So I think it's a different and better option than it was a year ago this time. So I think check again, and it may be that you'll be happily surprised, I hope, that there are more and better options on the marketplace than there were last year this time.
Yeah, I'll just echo both of your answers and say that healthcare.gov is probably a great place to start. And there are more navigators in the field now, including GHF is in the process of onboarding 2 navigators. And those are the folks who can really help you navigate the process, for lack of a better word. So our next question is from Jill Nolan. She's a reporter with the Georgia Recorder, and she has a question specifically about the survey results. She says 81% said they think the government should expand health insurance options. Is that a reference to Medicaid expansion, or are there other ways government could increase options?
Yeah, thanks for that question. So the survey question was purposefully vague, and I think it really speaks to people, primarily to people's values. So messaging research has shown that people may fundamentally agree on a lot of issues, and in this case, expanding insurance coverage, but those issues become more controversial when we start talking about particular solutions. So the survey results themselves don't tell policymakers how people want them to fix the issue, but they definitely show that the majority of state residents, no matter what party that they identify with, support this work at its core. To address the other part of your question, there are, Medicaid expansion is a huge way to increase coverage, but there are other options like subsidizing marketplace insurance. But I know a lot of our panelists have mentioned some of these things and probably have more ideas. So I'll, invite others to jump in as well.
Another potential policy solution is a public option. And we have seen, and it means different things at different levels. I think it was tossed around a lot in the lead up to the 2020 elections. But even at the state level, there have been some states that have implemented a public option, Washington State, Colorado, and Nevada most recently, that includes sort of a state-sponsored option on the marketplace. And so it would be sort of, again, targeting the individual market, the small group market, those people who buy their insurance, not through their employer. And then there are other policy options that are sort of floating around. I think that more at the federal level, So it's probably a longer time to come for things like an employer public option. So allowing employers to shop for a Medicare-like plan and offer that instead of having to go to the private market or always self-fund their own. So I think that there are lots of policy, but in terms of the immediate things in the state, I think that the two sort of ones that are sort of fully baked and that we see it playing out in other states would be a Medicaid expansion and or having additional ways, additional options on the marketplace.
Yeah, and I would just add that in terms of Medicare, there's also discussion about changing the age of Medicare, expanding what kinds of coverage like dental and vision, which seem to really create medical debt for a lot of individuals. So there are other policy options. Yep.
Thank you all for those answers. And you're segueing very nicely into the next question. So Congress is in the midst of drafting a budget bill, the budget reconciliation process that will likely include provisions to address some of the drivers that you guys have talked about today. Some of those provisions could include, Allison, to your point, an expansion of Medicare dental, vision, and hearing benefits. There's also a discussion of a federally facilitated Medicaid program to cover folks who are not eligible for Medicaid currently in Georgia. Could you speak to how some of the potential provisions could affect affordability coverage in Georgia?
Well, it's a lot. I mean, there are a lot of pieces. And I think, sort of at the very most immediate, certainly Whitney, all the provisions that you listed in the question about expanding Medicare coverage benefits to dental, things like, I think there's also prescription drug price negotiation that might start to, ratchet down some of the expensive specialty drugs or the Medicare drug benefit costs, and also just prescription drug costs generally. And then I think there are also the idea of letting the federal government step in to those 12 non-expansion states and offer something like a Medicaid expansion when the state doesn't do so. I think all of those things would go a long way. It targets different populations. And that's the problem we have, is that we have a patchwork in this country of people with Medicare, people with Medicaid, people with employer-based coverage, people who shop in the marketplace. So any one of these solutions doesn't really reach the entire population, but they all are meaningful. They all address healthcare costs and affordability in some way, and so that they will chip away at the problem. And then the other question is, to what degree do the other sort of social safety net programs, whether it's child care, expenses, or other types of sort of larger social determinants of health that Charles has talked about, how much of those also play in? Because what we're really talking about are structural wealth and income inequality issues. And if you give people more resources to buy the necessary items in their life, whether that's childcare or whether that's healthcare, it all comes out of a family's bottom line. And so I think we have to think about them sort of all together.
Well, thanks for that answer, Erin. So we have time for one more question. So this question is from Carol Maddox. She is with the Georgia Interfaith Public Policy Center. And her question is, mental health care access is also highly exacerbated by shortages in the mental health workforce, as well as inpatient bed shortages. While better coverage and reimbursement will go a long way to helping that, given the lag time in workforce development, particularly with psychiatrists, what do you recommend the state does to alleviate this problem? And Charles, since you mentioned workforce in your answers, I'll start this question off with you.
Sure, thank you. I think probably the most practical opportunity we have for that is to embrace telehealth and go to the outside market. Perhaps look outside of our state as to who can, what professionals outside of our state can practice in Georgia and help us fill that gap. I do think too, using our existing behavioral health providers and continuing to, because I know through COVID, they have certainly aggressively used telehealth. So I think that is, expanded some access, but we have such dire shortages in the state, we're going to have to go outside of the state to find those providers to fill that void.
So I'm going to draw on my previous experience representing social service providers. They sort of sit in this weird space between being a healthcare provider and being a social service provider. And so how those institutions are funded actually really matters. And I think, thinking about how some of those nonprofits that are providing those services and what other kinds of services they provide, and where their funds come from for other services, because it's the entity as a whole. They tend to be deficit funded entities that are providing a lot of behavioral health services across the country and everywhere. So I think that matters. I mean, Charles, you talked about FQHCs and the importance of them before, but they often have serious budget issues, and
Right.
just like those that they're serving, making ends meet is difficult for them, and so they struggle more financially than, say, healthcare providers like the hospital systems that are not the public hospital systems. And so I think we need to really look at that as well.
Wonderful. Well, thank you all so much for your time this morning, for your really thoughtful answers. I think we could go on and on, but so fortunate to get to hear from each of you this morning. So I will hand it over to Laura to wrap us up this morning.
Great. Thank you all. Thanks so much, Whitney. This was a really great conversation, and I definitely want it to go on longer. But here are a few things that I made note of during the conversation that I'll be taking away with me. First, just the level of dissatisfaction with our healthcare system among Georgians. 6 out of 10 Georgians are dissatisfied and think that our system needs change. That tells me that we as advocates, providers, policymakers, insurers, all of the other stakeholders in this system, we have to act with urgency on meaningful solutions for consumers. So we can't just nibble around the edges anymore. We really need to think boldly and move with urgency. The other thing, of course, is that the inequities that are baked into our larger society that we are seeing and that we've spent more than the last year and a half talking about, but especially the last year and a half, those show up in the same ways in our conversations around affordability and cost. And so to me, as health advocates, we really need to look at these immediate issues around healthcare, but we also need to really dig deeper and see how we can help resolve disparities based on race and based on geography and income more broadly. So we need to look at the social determinants of health and see how we can add value as health advocates. Thank you so much to Amanda, to Allison, to Aaron, and to Charles. You all, your expertise and your perspectives and your thoughtful discussion was just so valuable this morning, and I'm so glad we could all benefit from it. We are also really additionally grateful to the partnership of Alterum's Healthcare Value Hub for carrying out the CHESS survey in Georgia and for allowing GHF to advise on that. So thank you to Amanda and her team. For GHF, this event really represents the beginning of a conversation. As I said earlier, we believe that this data really compels us to act, and that we will need some collective action so that we can reshape our healthcare system and our public health system so that it works in the ways we want it to and produces the outcomes that we want to see for Georgians. We hope that all of you that are here with us this morning will continue to engage in that conversation with us and be part of the work. A few ways that you can do that. First, you can find the full report and the regional results of the survey on our website. I believe the link will be in the chat for easy access for you all, and we'll be sure, of course, to share that link widely as well through email and social media so you can find it. If you are interested in the more in-depth discussions of specific regions, we will be hosting local forums with local stakeholders about kind of the unique drivers of cost and affordability in their region of the state. You can visit our website to register for those discussions. We'll be holding the Southwest Georgia discussion on November 3rd and an East Georgia forum on November 10th. And we'll update the website once we get the North Georgia and Metro Atlanta forums scheduled. And those, both the November 3rd and November 10th discussions will be virtual, so you can join us even if you're not in that region of the state currently. For those of you who are specifically interested in kind of the medical debt and billing conversation, we hope that you will check out the hashtag Dish the Debt campaign on social media. That is a campaign that we are doing in partnership with Georgia Watch and Sowega Rising around story collection and advocacy for racially equitable, transparent, and fair medical billing and collection practices. So please join us on social media there. If you have a question or would like any further comment about the results of the reports or anything you heard today, please feel free to reach out to Whitney. Her contact information, I believe, is on the screen or can be put on the screen. And then finally, and in addition to today's speakers, I wanted to recognize a few folks who made this morning's event possible. First, to Whitney Griggs and Alex McDaniel on the GHF team for their incredibly hard work preparing for today's event and for getting this initiative off the ground. You all are doing great things. Thank you to Arnold Ventures, whose funding provided support for the survey, for this event, and for our coming regional events. And thank you to Spectrum Events for your IT skills and abilities this morning so that everything ran smoothly. We really appreciate it. And finally, thank you to all of you for tuning in this morning. We really appreciate that you chose to spend your very valuable time with GHF. And we look forward to continuing our work together in partnership with you. Have a great rest of your day, and we'll see you soon.